So in the MONARCH 2 trial, that was fulvestrant with or without abemaciclib for patients whose disease had progressed on an aromatase inhibitor. And MONARCH 3 is the first line trial of a non-steroidal AI with or without abemaciclib. And both of the trials, of course, were positive, and the data from both were pooled to look at more favorable versus more concerning patient subgroups. And it's really interesting. First of all, every single subgroup of patients with metastatic breast cancer benefits from abemaciclib, as we have seen with all of the CDK4/6 inhibitors. There isn't a subset of patients, even the most endocrine therapy sensitive, who doesn't benefit additionally from the abemaciclib. But what's interesting is that if you look across all the prognostic subsets, abemaciclib's, the patients did sort of equally well with the abemaciclib arm. Where it varies is how well they did with endocrine therapy alone, whether it be the non-steroidal AI or fulvestrant. So women with more endocrine therapy sensitive breast cancer did better with the endocrine therapy. They did yet better with abemaciclib, but the difference isn't so marked. Women with more concerning clinical characteristics, they did just as well with the abemaciclib as if they didn't have concerning clinical characteristics, but they did much less well with the endocrine therapy. So the differential benefit is much greater there from the abemaciclib. So the concerning characteristics were really, it's quite consistent with the picture we would expect for the patients to have less endocrine therapy sensitive disease. Patients with liver metastasis were particularly striking. Women with a shorter treatment-free interval, meaning their disease recurred either on endocrine therapy or within 3 years of stopping their adjuvant endocrine therapy. So women with a faster natural history, that's a more aggressive, highly proliferative disease. So women with grade 3 disease, also a greater differential benefit with the abemaciclib compared to grade 1-2 disease, for example. Women with progesterone receptor negative breast cancer, again, that tends to be more highly proliferative, higher grade disease. Those women had a greater differential benefit from the abemaciclib. So liver metastasis, shorter treatment-free interval, higher grade, and progesterone receptor negative. Women with bone-only disease, lower grade disease, longer treatment-free interval, they too benefited from abemaciclib, just not so strikingly in a differential way.